Hello dear friends, I am Dr. Bansi Sabu, diabetologist based at Ahmedabad. Currently I am Secretary for Diabetes India and past President of RSSDI. First of all, I would like to thank Association Physician of India API for this great initiative which is supported by Dr. Reddy's lab, and our primary intention is to reach out primary care physician across the country. What I am going to talk in next 20-25 minutes, a case-based approach for the treatment of patients with type 2 diabetes. I don't have any conflict of interest for this particular talk. Let me start with introducing that in India in 2019, one of the data had shown that we have 7.7 crore individuals have diabetes in our country. But recently, one more paper of 2021, which we are talking of 101 million, it means more than 10 crores people in India is already having diabetes, which is expected to rise over 2045 by 13.4 crore. The National NCD Monitoring Survey in India had reported that in a rural population also, now we have roughly almost all adult, if you calculate, it is 6.9% of rural population. According to International Diabetic Federation data, which is talking almost 7.2% of a rural adult population is having diabetes. So, this is what the status of diabetes in our country. But what is more problematic is we also have a lot of pre-diabetic population too, with a impaired fasting plasma glucose or IGT roughly between 9.3 to 24.4% respectively. Now, what's the more problematic? It's not the diabetes, it occurs in a younger age. So, we develop a lot of acute and chronic complication of diabetes. The acute complication of diabetes, if someone is insulin deficient like type 1 diabetes, they can have diabetic ketoacidosis. Then we may have a persons with diabetes who are on oral hypoglycemic agent on insulin, they may develop hypoglycemia or even diabetic coma, and some of them who can develop severe hyperglycemia, which is also a very important complication of diabetes as an acute complication. But the chronic complication of diabetes, which is like a macroangiopathy, which is an hypertension, artery narrowing, coronary artery disease, stroke, or even erectile dysfunction, diabetic retinopathy and nephropathy, which comes in a microvascular complication, diabetic neuropathy, which is a very common complication of diabetes, and even diabetic foot, which is a combination of vascular and neuropathic, both the problems leads to diabetic foot. But other acute complication because of diabetes, they may develop infection, they may get hospitalized, and some of the persons who develop some problems and getting admitted and they have already a diabetes, that again become a very important challenging task for treating these patients with diabetes. Classification of diabetes, primarily it's a type 1 and type 2. We also have gestational diabetes during the pregnancy if someone develops diabetes, or a hyperglycemia we call as gestational diabetes or hyperglycemia in pregnancy. There is a one more fourth variety of diabetes which is known as secondary diabetes. It may be because of post-pancreatitis or some other causes of diabetes like steroid induced hyperglycemia, that what we call is a secondary diabetes. Now, diagnosis is, this diagnostic criteria is that when fasting goes more than 100, but 70 to 99 fasting is absolutely normal. More than 110 we definitely call it's an impaired fasting hyperglycemia. Some of the condition and some of the countries in their organization had also talked, those who have fasting more than 100, we should consider them also impaired fasting hyperglycemia. But HbA1c between 5.7 to 6.4 is definitely a pre-diabetes condition. Diabetes is definitely when fasting plasma glucose goes more than 126, and if we try to diagnose them with more HbA1c, if it is more than 6.5, we call it diabetes. Now, what is the postprandial hyperglycemia, and which is a major challenge for Indian persons because of our carbohydrate intake in our diet. We people eat carb and thus leads to post-meal hyperglycemia. The post-meal hyperglycemia, if we see 24 hours rather than in 24 hours, 16 hours, actually we are either in post-meal hyperglycemic condition or a post-absorptive state of hyperglycemia, and that leads to high glucose throughout the day. If we see the 24-hour glucose profile, even in a non-diabetic and diabetic subject, we will find that in a non-diabetic subject, this peak may not be so high, but in a diabetic patient this will be very high, because there will be already a fasting hyperglycemia, which is a condition that leads to very high post meal hyperglycemia. Why PPG is more harmful? Because it increases the risk of heart disease. Postprandial hyperglycemia is also having higher risk of persons with insulin resistance, that also leads to more blood pressure, more of dyslipidemia and more of obesity too. Now, effective control for post-meal hyperglycemia or PPG control, one of the most important thing is the carbohydrate intake is to be reduced significantly. The carbs we have to make from simple to the complex carbohydrate. We have to give them more fiber in their diet. More control of a fasting hyperglycemia will also decrease their post-meal hyperglycemia. More of a exercise, particularly insulin resistance to be decreased. So, that is a muscle strengthening exercise, and plus we have to give them some medication to control this post meal hyperglycemia also. So, depending on the condition after lifestyle modification, if someone's post meal hyperglycemia is not getting control, then definitely we have to add some molecule, and particularly alpha glucosidase inhibitor is a choice of molecule for managing type 2 diabetes patients, particularly to control postprandial hyperglycemia. It prevents digestion and absorption of carbohydrates by inhibiting the terminal step of the carbohydrate digestion at the brush border of the intestinal epithelium. Carbohydrate absorption is shifted more distally in the intestine, therefore, it is a delayed absorption and this peak can be significantly decreased. And here we have in India two molecules, acarbose and voglibose. Here voglibose I will be talking is voglibose belongs to category of alpha glucosidase inhibitor. It does not have any secretagogue action and does not cause any hypoglycemia, because nothing to do with the pancreatic beta cells. So, alpha glucosidase inhibitor does not lead to any sort of hypoglycemia. Alpha glucosidase inhibitor reduce the absorption of carbohydrate. Without AGI there will be faster absorption of carbohydrate from proximal ileum or jejunum, while with the patients with the who are taking alpha glucosidase inhibitor, it will delay the absorption and the persons will have reduced and delayed carbohydrate absorption. So, the peak of post meal hyperglycemia can be significantly reduced, and this is how you can have the peak can be significantly reduced with alpha glucosidase inhibitor. Voglibose in diabetes patient management, as it is a competitive alpha glucosidase inhibitor which discovered in 1981. It is available since last almost 25 years or 30 years in our country. In Japan it is in 1994 and since last 20 years in our country also. It specifically targets post meal hyperglycemia with no risk of hypoglycemia, and there are multiple papers to suggest that, and it is very effective to control post meal glucose, and not only post meal glucose, even our HbA1c also. And we have availability of fixed dose combination with voglibose with metformin, voglibose, glimepiride and metformin, a unique combination of sulfonylurea, metformin and voglibose in our country, and which is approved, and many of the companies have this combination which we use for our country for many of our patients. This triple combination which is used in a number of countries, but India is one country where we are using it very often. If the glycemic effective are not met with two medication, the RSSDI, our national society, recommends the use of this triple drug as a patient-centric strategy for our patient whose post-meal glucose is not getting control. So, where you will put the voglibose in therapy? Uncontrolled diabetes who are already on a dual drug combination, those who consume still high carbohydrate intake even after the diet control whatever which we could explain the patient, who are obese and overweight patient, who have not started on insulin. So, prior to start with the insulin, the basal bolus, once you put the patient on bolus therapy, that also control the post meal glucose level, and the elderly people with type 2 diabetes, they are the right person to whom we can start this triple drug combination. The rescue therapy is always the insulin whenever the sugar is not very good control, or these patients who are already on triple drug and not getting control, or they get hospitalized where we want to put them on a better control of the diabetes. This newer technology, because this is a triple drug combination and 3 drugs are already combined, this combination which is a newer technology, the size of pill is very important, and this new pill which I am showing on the slide, you can see that before and after there is a significant decrease, and it is also in a core form. So, you can divide and you can give it in a 2 form also. So, reduced pill size is very easier to swallow. Now, let me talk with the case study, because that I think I will able to explain in a much better what type of patients where you would like to put the patient on this triple drug combination. Let me start a garden variety of type 2 diabetic patient coming to your clinic. A 38-year-old female obese person visited the hospital with the chief complaints of increasing urination, dizziness and fatigue. This is a typical some symptoms of uncontrolled diabetes with a past history of type 2 diabetes. She was already on a metformin twice daily, and now see the postprandial glucose is 191 with 7.8 with fasting plasma glucose of 150, and here LDL is also uncontrolled with presenting symptom, and the complaint we could understand that she is uncontrolled diabetes who is on metformin. What we have done, counseling we have done, try to explain the diet part of it and added a patient on a single pill which contains 2 milligram of glimepiride metformin, and definitely we started her on lipid lowering agent. Also patient was counseled for the hypoglycemia too and to maintain on a regular basis. After a week of follow up, we could see the patient sugar, post meal sugar had come significantly down. Patient tolerated the medication well. She was advised to visit the hospital after 3 months, but in between we keep on calling the patient, or there should be a continuous maintenance, because sometime a patient who started with a glimepiride, we may decrease it from 2 to 1 milligram, because we have a combination of 1 as well as with 0.5 milligram combination is also available. So, sometime we have to reduce the glimepiride dose in this triple drug combination if the sugar get better control, and in follow up we can see that patient LDL control very good, HbA1c decreased significantly down to 6.7, and this current case highlights the importance of regular medication, adherence to the effectiveness and safety of glimepiride combination with metformin and voglibose in person, and it has been given with the biggest meal of the day. The other case, which is a 45-year-old male, again with a uncontrolled diabetes with a delayed wound healing, reported experiencing a cut on his leg with few days ago. While farming, patient was already type 2 diabetic patient, and a glimepiride and metformin both was given. Patient HbA1c is very high, he consumes very high amount of the sugar, I mean the carbs, not the sugar actually. We try to change the carb content of the diet, and the LDL cholesterol is high. This patient is already on uncontrolled diabetic. This patient put on a glimepiride, metformin, voglibose and metformin 3 times daily with all 3 times daily, and patient was also started with a gliptin and SGLT2, and you can see the patient sugar had started coming significantly down, and the patient control with a diet also changed, and sugar is very well controlled after 3 months. The other case, a 50-year-old female patient visited the hospital again with the chief complaint of some GI infection with unbearable pain in her legs. When we discussed that she was taking a carbohydrate rich diet and she is having rice and sweet, even we could change her sweet part of it, that is completely stopped, but the sugar is very high, 9.5 HbA1c. This patient on her subjective symptoms, on laboratory investigation, her condition was diagnosed as type 2 diabetes with uncontrolled blood glucose level. The treatment when she started with a glimepiride, metformin and voglibose, after talking to the doctor and discussed with them. In addition to this, she was prescribed medication to treat bladder infection, urine was cultured, and accordingly we have started her on an antibiotic also. So, after lifestyle changes and advised to return to the clinic after 2 months, and you can see that visit 1, the postprandial glucose level had come significantly down with 141. Without putting the patient on insulin, we could achieve the target A1C of less than 7. So, the current case study highlights the importance of using the single pin combination of glimepiride, metformin and voglibose as a rescue therapy, which effectively lower the elevated postprandial glucose level in patient with type 2 diabetes. The importance of lifestyle is here very important, because it is not only control the diet, lifestyle and physical activity with a low calorie, low fat diet with a 150 minutes per week of a moderate exercise have reduction of risk reduction of type 2 diabetes by almost 67. Now, here I am not putting only low calorie, it is low carbs also, which is very important, or a complex carbohydrate diet which is also very important with a high protein, which we should recommend to our patients. So, to conclude my talk, a type 2 diabetes management in a rural Indian population requires a comprehensive approach that includes early diagnosis, adherence to treatment, lifestyle changes and optimal medication combination. Addressing PPG, which is regarded as a significant determinant of HbA1c in India, essential for successful management of type 2 diabetes, establishing optimal glycemic control. Voglibose in combination with other diabetes medication can help manage postprandial glucose level and improve glycemic control. And in addition, lifestyle modification, patient education and consistent follow-up are essential for the effective management of elevated blood glucose level in patients with type 2 diabetes. Thank you. Thank you for your kind attention, and thanks API for this wonderful opportunity, with thanking DRL Dr. Reddy's Lab for this opportunity also. Thank you very much.